Good morning again. Welcome to this session on medical device unique identification for devices. And we're going to get started by welcoming all of the speakers today. We are really very honored and pleased to have a wealth of expertise coming from the industry, coming from the healthcare supplier perspective, and of course from the regulators to be sharing with us their experiences on the implementation of UDI. And for that, and just before we get started, just reconfirming our traditional housekeeping messages to remind everybody that this session is being recorded for its future availability at the Coalition's website. We have a simultaneous interpretation available to English, Portuguese, and Spanish. You can access that through the link that is located at the bar menu in the bottom of your screens. The microphones of all the participants are closed so as to prevent background noise. And we kindly request for all of you to post your questions also using the Q&A feature available at the Zoom platform, so we may be sure that all your concerns and questions are properly voiced to the presenters. And for the speakers, we appreciate your turning on your cameras during your presentations. May we maximize the quality of the interpretation of the various languages. We are then ready to get started with the agenda today. We will have this session kind of like divided in two mini sessions. One, the first, where we're going to have John Terwilliger and Cynthia Shumway from the private sector sharing their experiences with us. And then we will have the regulators that we are honored to be hosting today. For the first part, I'm going to be moderating. And then for the second one, it is going to be Patricia Pineda that is going to be moderating. With further ado, I will like to introduce and really apologize again, John, for my inability to pronounce your last name correctly. John Terwilliger, he's Senior Program Manager, Global Standards and Serialization Office Corporate at Abbott Park. He co-leads the Global UDI Program Management Office. He's also Program Lead for USFDA UDI implementation, and he has over 13 years of experience at Abbott and formerly at GS1 US and Baxter Healthcare. So John, thank you very much for joining us today. The floor is yours.
Oh, thank you very much. So I'll share my screen then, right?
Yes, please.
Sorry. Did it come up? No.
Not yet. Interesting. We just tested it and worked.
You can hear me, correct?
Yes, I can hear you.
Can't seem to get you up though.
Do you want me to share my screen? And you just let me know when to advance?
Yes, please. Well, there I am.
Okay, it seems that now it's coming.
Okay, there I am. Sorry about that, everybody. Again, John Terwilliger from Abbott, and I'm very, very pleased to be able to speak with you today, and I'd like to thank for being invited. I'd like to talk a little bit about the key issue around really implementing UDI is this kind of foundational requirement that we need to follow standards and to follow the existing guidelines. This consistency is tremendously important for manufacturers to really provide the type of data and meet these needs of UDI. And it really rests on two things. One is the UDI system as defined by the International Medical Device Regulators Forum, IMDRF. They have issued a document that provides a framework and definition of what UDI is, which should be followed and used to implement UDI in various jurisdictions. It's a very good document. It provides a very consistent definition, something that's really very doable. The other key thing that I'd like to also talk about after we talk about that is the importance of adopting the global medical device nomenclature as the requested nomenclature. There does exist a lot of other nomenclatures out there. However, we really do want to encourage that be adopted, and I'll talk more about that. Before we get started, maybe it'd be a good idea just to make sure we're all kind of grounded as to what is a unique device identification. I think sometimes these terms become a bit confused. I think it's important to note that a UDI is a series of numeric or alphanumeric characters that is created against a globally accepted device identification and coding standard that allows the unambiguous identification of a specific medical device in the market. And it's composed of two parts. There's the UDI DI, or the device identifier, which identifies the product, and then the UDI PI, or UDI production identifiers that provide production level information such as lot numbers, expiration dates, or serial numbers. And I think it's also important to note that the word unique does not imply serialization of individual products. The production identifiers that would be shared are those that are already currently on the label. So there's no requirement to create new production identifiers or suddenly start serializing products. It's more about whatever's on the label to share. And on this example here, we have a barcode that would be on the product label, and then here's below is the UDI, the unique device identifier, using the GS1 standard. And so we have the 01, which is the DI, the device identifier, and then the 17 and the 10 there, which are the lot and expiration dates. So this would be an example of how we uniquely identify a product. The IMDRF defines the UDI identification system as having a couple components here. It is a system, and it's intended to provide a single, globally harmonized. I think it's really important that the hope is that we will do this consistently around the globe for the identification of medical devices through its distribution use, requiring devices to bear a globally unique device identifier, which we talked about on the previous slide, and to be conveyed using automatic identification data capture. A rather fancy word for barcoding primarily. There's certainly other things that would fall in this, but I think the bottom line, we're talking about barcodes. And if applicable, it's human readable information based upon the issuing agency's standard with the UDI DI of that product linked inside a jurisdiction-specific public UDI database. So at the bottom here, here's the components of a UDI system. There's the medical device label. There is the AIDC, or the barcode. There is the human readable information there to the left against a standard. In this case, this is done against GS1. And then on the far right would be the UDI database of UDID, where information about that product using the UDI device identifier as the key would be stored, and manufacturer would provide all sorts of information to describe that product, master data. I think it's also important to note inside the IMDRF, they define kind of fundamental steps in the establishment of a UDI system, and they have 4 basic steps that the document talks about. The development of a standardized system for unique device identifiers, UDIs, the placing of UDIs in a human readable and barcode format on labels, and in some cases actually on the device itself, the submission of core UDI data elements to UDI database, and last but not least, they provide some guidance on setting up of appropriate transitional implementation arrangements to ensure a smooth UDI system implementation. And I would, from a regulatory perspective, we hope as manufacturers, that regulatory agencies will embrace the definition of the UDI system as defined by IMDRF. The more consistent we are around the globe, the easier it will be to actually meet these requirements and provide high quality data, and also allow the various UDI databases around the world to be compared for regulatory purposes. So I think there's another real opportunity there for data sharing comparison by ensuring consistency wherever possible. Particularly at the label level around the barcoding, that's very important that the issuing agencies be recognized. There are 3 primary ones, the GS1 US being one of them. And using that, because requiring different barcoding on products would require, different labels, which would be not good. And I'll talk more about that in a minute. A little bit about, what are the benefits of a UDI system? And this is what IMDRF thought about, and this is how in their document. And I think I kind of highlighted here that it's really about improving patient safety and optimizing patient care. That is the focus of UDI, and that they feel the real benefits are. And they list, 5 items of ways this will help improve patient safety and optimize patient care. Traceability, adequate identification of medical devices to distribution and use, identification of medical devices and adverse events, reduction of medical errors. And here they're probably they're implying use of once things are barcoded, they can be scanned at point of use or in the point of care setting, so it can be kept very clear as to what products were used. We'll go into electronic patient records, which will allow this last one, the documenting and longitudinal capture of data on medical devices for studies to show efficacy, et cetera. And I think it's very important to note that UDI is not about pricing and cost control. It's not intended to do that. That potentially could be an add-on once you have this data in place, but into itself, it is not about those 2 topics. I'd like to talk a little bit about nomenclature. There's been a lot of discussion around as to what this is or is not. This is a standardized name. Again, I think a name or a term given to a type of medical device, irrespective of the manufacturer. The nomenclature, this kind of standardized name, identifies medical devices that have a common function and a similar design. The most used one out there around the world is the Global Medical Device Nomenclature. The Gmdn maintains the translations in Spanish and Portuguese and others, and access is free to manufacturers. So I think it's important to note that its use of the Gmdn is not a financial burden. A few things around nomenclatures. We strongly support as manufacturers the use of Gmdn by regulators globally and as recommended by IMDRF. So the IMDRF document definition of the UDI system specifically calls out the use of Gmdn as the nomenclature. I think it's important to note that multiple nomenclature raise significant regional and global challenges for the healthcare industry to implement, train, and maintain, which leads to errors, et cetera. Jurisdiction-specific nomenclatures are costly to implement and more costly to maintain. The jurisdiction-specific nomenclature are negative for patients, health systems, the industry. And I think it's also important to note about nomenclatures that they are not static. Changes are made to reflect new products and technologies. So any system that kind of makes the assumption that this is like a field that is unchanged, or once you know what it's done, is not true, because they are not static. And I think it's really important to note that Gmdn should be a database attribute of products because of this fact that they are not static. Here's just a simple example of how UDI and Gmdn work together. Here on the left, we have a specific product, which has a unique device identifier from a single supplier. In this example, Hudson, we're talking about a syringe. And then, but they would all have the same term, whether or not the syringe comes from Hudson, Brooks, or Woods, and they each have their own unique device identifiers. So, but they share the same common Gmdn code 47017. And the term name is the general purpose syringe. So again, these are all general purpose syringes, but they each have their own unique device identifier depending on the manufacturer. So this is how they work together. I'd also like to just touch briefly on another thing that sometimes gets kind of confused, is really around the idea of a product and service classification. And this is a coding given to products or services part of the procurement process, including spend analysis. It usually covers a wide range of products that are used throughout industry, whether that be medical devices, drugs, nutrition, clothing, consulting services, or if you can think of the item or a service, there's a code for it usually. Due to these wide range of these types of products, descriptions tend to be simple. They are not really suitable for other purposes such as product safety assessment, et cetera. An example of a well-known product classification is the United Nations Standard Products and Services Code. I think it's also important to note that classifications are also not static. Changes are made to reflect new products and services or improved usability. Things that maybe weren't as used or become more diverse may be broken apart. You may get two codes where there used to be one, et cetera. And I think this is also another example, because this information is not static, that this classification is very much a database attribute of products. And here's just a really simple example of the UNSPSC code. And UNSPSC codes, they're hierarchical. Most classification systems aren't. This is a four-level hierarchy between segments, families, classes, and commodities. So there are many different segments. In my example here, 44 is the office equipment and accessories. One of the families under that is office machines, their supplies and accessories, 10. There are a number of classes underneath that family. And for my example, we're going to use writing instrument 17. And the specific commodity that we're talking about is ballpoint pens. Therefore, all ballpoint pens would have UNSPSC code 44101704. But you can also see from a spend analysis, you could roll up all ballpoint pens plus other sorts of things into everything that are writing instruments, whether or not you're buying pencils or et cetera. Or you could roll up everything to the class level, every spend analysis on office and desk accessories, which could also be rolled up to the family, which could be rolled up also to the segment. So this really allows a roll up of spend. It's many times used in the procurement process to identify potential suppliers and maybe potentially evaluate the suppliers you have across these various categories, et cetera. As examples is how it's commonly used. And with that, I'm done. And I'd really like to thank everybody for paying attention. I hope that was helpful. And I look forward to maybe the questions, to answer any questions that may come up.
Thank you very much, John. And then let me proceed to introduce Cynthia. Cynthia, as the Director of Business Applications for the Supply Chain and Shared Services and Intermountain Healthcare. Cynthia is responsible for supply chain, facility management, clinical engineering, and non-supply chain contract systems, as well as EDI and process automation, including RPA. Cynthia has led Intermountain as early adopters on UDI implementation from transactions to point of use capture. Cynthia brings over 30 years healthcare supply chain experience. She participates in the Healthcare Transformation Group, HTG, GS1 work groups and leadership team, and other industry forums to promote industry standards and implementation of leading practices. Cynthia graduated from Brigham Young University, is certified in TPS Lean, continuous improvement, and change management. Cynthia, it is really a great pleasure to have you here, and the floor is yours.
Great, thank you so much, and thanks for the invitation, and hopefully I interpreted the request correctly, and we'll talk to you about what you would like to hear today. So try and share my screen now. Can you see my screen?
Perfectly, thank you.
Great. Okay, so yeah, so we just wanted to share a little bit about our journey. As we implemented UDIs, we were probably a little unique in that we were early adopters and had access to some technology. Just a little bit about Intermountain that I'm always asked to share when presenting. We are based in Salt Lake City. We're an integrated delivery network. Our paths were growing. So we have healthcare, our healthcare plans across the Western United States. And we've now actually started to do acquisitions, and we a recently announced merger that closes April 1st with SCL Health, which will expand our hospitals and growth throughout the Western United States. All right, so today I'm just going to share, kind of highlight what I'm going to share with you. I'm going to tell you about where and why we began this journey, our advocacy and early adoption efforts, UDI regulation and some opportunities, and then the UDI in use, like where we are today. And then John and I think will entertain some questions. So this is our why. I mean, imagine a world with perfect data. What could we do with that, right? That's the pain point for so many things, so many areas. But patient safety is top of mind, you know, reducing labor, inventory management, all of those things which also reduce cost, revenue management, outcome analysis, transactional processing. Those are just a few of the things, but these are the things we imagined. And we started our journey quite back in the 90s when I was just a wee thing, just starting my career. And we really were a conglomerate of 24 hospitals and not necessarily an integrated delivery network. And so as our company started to shift to be an integrated one company versus, you know, just 24 independent hospitals, we actually had like 26 disparate databases. So if I show you my next slide, you'll see this is where we were, and I called it, this was our state of chaos. And this is just one example that you could find across any system, probably, you know, so many different ways to identify who we are, several different ways to identify who I was doing business with, many different ways to identify the exact same product, because we all had our proprietary numbers and we all thought we had to have our proprietary numbers. I remember one of the first conferences my company sent me to was around the universal product number and the Department of Defense in the US discussing how we were going to have one number that identified everything. And being this optimistic and, oh, wow, I'm going to go back and do this. We went back and we had some proprietary systems. I had some developers and I said, we need to make change so we can be prepared for this. So back in the 90s, we actually standardized. We took all of, before there was a lot of tools to do this, it was really painful, but we did one database. So we had one item master and one contract master, and we created the fields for this UPN. The benefit to that is it actually really led us into being able to take advantage as things came about and we started to really move this path with the UDI. So we became an advocate and an early adopter. So even before there was regulation, there was a lot of activism by several groups on all sides of the fence, from regulators to manufacturers, providers, technology solution providers across the board. And there were several different groups that were meeting and having these discussions about what our needs were and what we could do. And there was certainly discussion before the rule came out as to what this would look like. Those groups eventually merged into three key groups. One of them that we rallied behind was with GS1 US Healthcare. And in the US, as you know, you're probably aware, there's multiple issuing agencies. But as a group of healthcare providers, we really felt like we need to get behind one. We really believe in a standard, and that was the best way to do that. And we rallied behind GS1. The other thing we did is a group of really like-minded providers, IDMs, that had the means to be early adopters, and we formed a coalition. Felt like maybe that would help give the 10,000 plus providers a voice in this space, and that we could help move these things along. And so it consisted of Geisinger, Intermountain, Kaiser, Mayo, and Mercy Health. And later on, we added FMLS. But our drive really was, let's get this into place. And we started this work well before the regulation, the rules came out around the regulation. We had working calls. This group met once a week for years. Now we actually still meet once a week, but we had summits. We hosted summits. We brought in solution providers and manufacturers. We talked through what the pain points were. We offered services out, like, so you're discussing about where you're going to put your label. Well, then send us your product, send it to us, and we'll go meet with our clinicians and we'll say what works best. Does it work best if this label's here on the spine? Does it work best if it's here? How can you best read it and interpret it? And so we really appreciate the companies that took advantage of that, that had the discussions and listened to what our needs were to be able to implement and do this. We also did a lot of education, and we continue to do education because it's still one of our opportunities. And that's both internally and externally. Well, there's a group of us here today that understand this, that do all this work, and in every company, that's how it goes, right? So at Intermountain Healthcare, if the questions came up, it was, oh, just talk to Cynthia. But it needs to be more than me, right? If I'm really going to make standards work, I need to make sure that my buyers understand this. My contracting team, as they're working through contracts and they put it into the language, when the manufacturer wants to redline it, they need to understand why it's not something they should just redline, how it is important, how it affects us downstream, upstream, and downstream. So a lot of education. How on the manufacturers, if I call and I really want to be able to use the UDI and Gmdn in my transactions, their customer service needs to understand what that is and not always go to the default of the numbers we always used. So we did lots of things like that. We worked on data exchange. It was pre the good ID. So, could we use the GDSN? And working to prepare our technology partners. We have some gaps there, right? Because before the rules came out, in its simplest sense, it was a one-to-one relationship. And so early on, a lot of the solution providers for us developed, okay, we heard what you said, you need a Gmdn associated with a unit of measure. As I start talking about opportunities and pain points, you'll see that's sometimes we need multiple Gmdns associated with the same unit of measure. But early on, that was not the understanding and the interpretation. And so we've had to do some rework there. The other group that came out after the learnings that we've rallied behind is our ARM learning UDI communities. And they've really been great to facilitate and I think help both the providers and manufacturers as well as the FDA have a forum to talk through some of these things that are pain points, to listen to both sides and see if we can come to some solutions on improving the process and moving forward. One thing I want to note as part of our advocacy, I guess, Intermountain Healthcare, I had this wild-haired idea one day. We were hosting the summit for the healthcare transformation group, and I had an idea that we should put together a video. And so we made a parody around data standards if the grocery industry operated like healthcare, and just to kind of prove our point, to prove this is our problem out there, and we all have responsibility to make a difference and improve that. So I put the link here. Hopefully when you see the slides, you'll have a chance to go out. I watched it again yesterday, and it's surprising for as many years as I've worked on this and as frustrating as this can be, because I'm like, oh, it's just common sense and logic. We should just get it done. I still am very passionate about it. And there's just so much opportunity. I get really excited to talk about standards still today because of the opportunities that we have. All right, so then the regulation came in 2013, and we are super excited about that because, while I think we all believed in it, oftentimes we need things like that. We need an internal audit. We need a regulation to help us move the mark a little bit. But what we soon realized is that the regulation is actually the low watermark, right? That it tells the manufacturer that you need to label your product. But what it doesn't tell them is that you should consider, when you're doing this, not just checking the box that you met the regulation, but did you improve the process? And there's several companies, Abbott's, John and his team are an example of one of them, who really looked internally and said, how can we use this to improve our internal processes? How can we use this to improve our processes between our customers and down to the, so there's so much opportunity, right? To just create operational efficiencies, to really, how do we utilize this to improve patient safety? How do we utilize this in the procure to pay process for that perfect order? How do we utilize this to do comparative analysis, make sure we're using the right product for the right patient and having the right outcomes? And if you're not familiar with this picture, I should probably get some background here. I'm from Utah, a desert state, which has been going through a significant drought. One of our favorite places to go for recreation is Lake Powell. And so this is a picture of Lake Powell. And from just this past year, and you can see how low our water has become because of our drought. So that's just a sidebar there. All right. So here's some of our early adoption learning, and I call them opportunities because I'm ever the optimism. John can probably attest to that. It just seemed like common sense to me. Like, oh, we're going to get the same number and we can do all of these great things. I never realized how hard it would be. And I think my kids can thank this project for me learning to develop more patience. So I had a lot of learnings, and I had to listen and see, oh, wow, why I just figured the manufacturers had all this information and can provide it to me. We understood that, wow, they have challenges too. They have disparate systems. They have to meet global needs. And that's one of our challenges, is that sometimes when we're wanting something here in the US, they're saying, yeah, but we can't do that because we're waiting for the rule to come out in this country or this country. And to John's point earlier, that's why we need to make sure we follow the standards, because we all impact each other. So there's a disconnect between meeting the regulation requirements and operational downstream effects. There's a big distinction in companies that we've worked with, where you can see the legal team went in and said, okay, we got to meet this requirement, and here's what we did, versus those that, as I mentioned, included their operations teams and really looked at what are the other opportunities and what are things that we can do by implementing the UDI. An example would be, we have one company, as I mentioned, varied interpretation of the rules, fit, form, and function as to when you change a DTIN. So working with a company, because as I mentioned in the beginning, we had 1-to-1 field, and I could have at any point in time having a system with 24 hospitals, 200 plus clinics, the same product with different variations of GTINs. It's really challenging to manage, because what we still have gaps in is, when am I going to see the new GTIN? Sometimes there's a reason to have a new GTIN, but sometimes we use that number, or the number is used to manage lots of different things that could be managed with other AIs, such as lot, point of origin, or country of origin. Even we have had a manufacturer within the United States who had two different numbers, whether it was manufactured in Nashville, Tennessee, or in Anaheim, California. All of those things caused major problems to the providers. Some of the systems we integrate with, so even if you modified your supply chain systems, could that integrate into the clinical systems, and could they hold both of those fields? And so lots of opportunities working with solution providers and really understanding the reasons why a GTIN should change and when it shouldn't. We still have challenges around transparency on the timing of it. So legitimately, sometimes those things need to change. When am I going to see that in my pipeline? Can I communicate that back in my PO transactions so that the provider can anticipate that and make sure that things are lined up? If I catch that in supply chain, then it makes the path for the clinician much easier. Going into a project with a clinician and saying, hey, we want you to start scanning, but it's only going to work 30% of the time because the product doesn't have the label. You can't find the label. There's too many labels, or the label, the numbers changed and it's not in our system, is really challenging. And so we've had to work through those things of how do we identify those things. Fortunately, there's avenues to do APIs into the Good ID and other aspects to help improve that, right? As an early adopter, we certainly felt a lot of that pain, but hopefully paved the way for other people to adopt quicker. So I mentioned variation in labeling, technology solution provider gaps. That's definitely a challenge on all sides, I think. And so what happens is, I think it's always important to make sure that they're part of the dialogue, get them on board so that every company is not having to go and make changes and customizations that are expensive. The other challenge I think we've had in the US is slow provider adoption. And what it's really caused is a manufacturer to have a foot in both camp. Maybe when you ask as a group, we'd go and say, why do you have 3 different types of labels on here? And one of them might be a label of their manufacturer number that they'd assigned, and they can't get rid of it because you've got too many providers that were using that number to scan with. And so I kind of feel like there's a point where we just need to rip the bandage off and maybe put some expectations on the providers as well, so that we can move quicker and make more progress, because there's so many opportunities. And the other piece, because of that, I think that leads to that on both sides, is slow transactional adoption. So part of those opportunities to improve our process, to have that perfect order, it's really, there's lots of gaps. There's some suppliers that can do it and some that they'll take your field, but they really continue to do business as they've always done business. So maybe some missed opportunities there. Okay, so where is Intermountain today? Just kind of sharing some things. I shared some pain points, but we've really tried to embrace this and make the most of it. In our operations, in our core item master and contract master, about 80% of our total item masters there. Now, keep in mind, we have equipment and other things that, and different types of products that this would not pertain to. In our OR and cath lab, where we've really focused, where the class 2 and 3 items are, about 89% have at least one UDI identifier associated with them. We use multiple exchanges to get our data. We use the Gmdn, we use the Good ID, and we also use data from our GPO. Although I think we send more data to them that they can share with others than we get from them. We also developed a little app that if we're bringing up a new area, we can just go do a quick scan and to make sure that we have the GTIM information for all of those products. We developed out, we have 9 supply chain mobile applications as part of functionality we already had. Within those, we developed out that we could scan the product for using the barcode on the product and not a label that we've had to put on or anything in all of those aspects. It's improved all of those processes immensely. And an example is an 80% error reduction in receiving. So essentially what it does, where a receiver would dig for a packing slip and then receive against that, or look at this and say, all those boxes look the same, they're the same item, receive against that. And then we'd have to go back and those are really 3 different products. We catch that all with the scan. So it's eliminated receiving errors and rework very significantly, and it has been a really big win. And the change management, and that made the change management much easier within our departments. At Intermountain Healthcare, we've enabled all of our EDI transactions so that we can send and receive the GLN, the GTIN, and UDI information. And we're actually actively working on a project with John now, where we're really trying to work on our recall management aspect. And so while we can do lot and serial tracking, some products, it adds a lot of cost to a process. And so not every product makes sense to do lot serial tracking. So what we're working on is that if I can get that information in an advanced ship notice, in an 856 advanced ship notice, if I can get the UDI information in that helps me right now, instead of having every facility go say, hey, do you have this lot sitting on your shelf, right? It tells me right from the get-go, you know what, I never sent that lot to that facility. They didn't do it, I don't have to worry about it. So we're really working to see how we can improve that process right now. But we use that in all of our transactions, and we're anxious for more suppliers to be able to do that as well. Clinical integrations. So we've worked heavily in clinical integration, specifically in our ORs and cath labs. Our cath labs are doing great. They're at 90% plus, probably close nearer to 100 at this point. Scanning their products, it helps us with contract management and ensuring that they're following contract. It's giving us the data we need to improve process and safety. And in our OR, we are documenting it, right? They have to, for implants and the medical record, they have to document it, but our scanning really varies. And that really is we started, as I mentioned, with, hey, sometimes it's going to work and sometimes it's not, right? Because the ruling had, you know, a 7-year plus implementation. But now we really are struggling with the solution provider, and we're working with them to simplify it for the clinician. I guess frustrated is probably the right word. I get frustrated that I feel like sometimes we just don't take advantage of what we could. So for instance, right now in their system, they have to stop, click on something on the screen, the right field, and then scan it, but it's not parsing it correctly. And so in my dream state, right, every system would be able to interpret, parse the data correctly, and put it in the fields it needs and make it really simple for the clinician. And so those are some of the things we're working on with our clinical groups and their systems today. So just to close, I still imagine a world with perfect data. I hope we can check off some of these things before I retire. It's been a long time coming, but there's so much opportunity with the UDI to get us to that perfect transaction that improves that process, so we're not reworking data, that we get the right supply, that we don't send the wrong unit of measure, we improve patient safety, we get alerts because, oh, this one shouldn't be used, this one's not on contract. We are doing quite a bit of work already, and we've been partnering with several groups that have been utilizing this data to enhance our comparative effectiveness analysis. And we see how it's impacting the change in practice and improving the cost to the patient, which is in addition to safety, which is really what we want to do. So thank you. Thank you for letting me share.
Cynthia, thank you very much. I think it has been really, at least for me, an eye-opener session. It is really, really interesting to learn. I mean, the extent of the impact of UDI once we get much closer to the patient. And really, really thank you very much for sharing all this with us. I have a couple of questions that were posted via chat. They're not, we cannot read them through the Q&A, but I would like to voice them. We have one from Brazil, Sergio Madeira, and his question is, on the hospital side, how do you work with non-sterile implants offered in containers with instruments and implants as well?
Yeah, so with the plates and screws, that is everyone's challenge. We've experimented with several different things, having sheets in the bottom that they can scan which one they took. That's being piloted in some sites. We haven't come up with a great solution to that yet. We've had the CP team, when the product gets back into their area, where they will scan and validate that the right thing was associated, but that is still one of our challenges to work through.
Okay, thank you very much. And I have here also via chat a question for John. It says, except for meeting, and sorry, this question is coming from Michael Simpson from the FDA. It is, except for meeting the regulation requirements, what are the benefits for manufacturers in complying and using UDI and Gmdn?
At ABET, we have worked very hard to make sure to identify and get benefits. To just do regulatory requirements, to do them, meets the regulatory requirements, but there hopefully is always something more. I would offer up that I think UDI is one is helped us gather up and kind of centralize our product information, which is used for many purposes. One is to share with our customers. I think it's also allowed us to kind of maybe look through some of our processes around how we provide product numbers and how we assign barcodes and where barcodes are and are not products. I think it's been a real cleanup exercise for us. And I would offer up that one of the key things that we have worked at is to make sure that we do meet these requirements, not only for the regulatory requirements, but also for the customer. And I think I'd hope Cynthia would raise her hand and say, good job in this regard and providing good data and good barcode products for their use to drive patient safety. And one thing I always try to remind everybody, all of us will be patients at some point in time. And if we're not patients, which will happen eventually, the people we love will be patients. And UDI is really around patient safety. So I think that's a real plus. So I think that should never, ever be forgotten. We also have used UDI as a way to get GTINs, global trade numbers, or UDI device identifiers, into EDI transactions. And Cynthia mentioned that. We've worked very extensively with their Mountain Healthcare to do that. And through that, we've been able to increase the EDI use between us and customers. And particularly, Intermountain is one of our star pupils, so to speak, and we're very glad to work with them. And as Cynthia said, we have some more work to do. Gmdn is certainly has tremendous regulatory use. We don't use it per se, and we understand our products. So it's probably not a question of us understanding it, but from a regulatory perspective, I understand why it's asked for. I think it's quite important. I think the key thing that we are concerned about is that there's consistent adoption of the one medical device nomenclature and not the creation or adoption of others. That's because multiples doesn't add any value, and that's, we believe, rather strong in that. And again, I hope I answered the question. Cynthia may want to comment.
Yeah, if I can add to that, I would be happy to talk to any manufacturer who thinks there's not value for them to implement this. Abbott, as an example, I'll also call out, Dave Reed's retired, but with Cook Medical, you know, I know that they used it to standardize internally so that they had a common number amongst all their different distribution area or manufacturing plants. They used it to improve their processes internally. And then when they did that, there was downstream benefit for us because then they could transact with it. Their team, we could call in and say, we have a question about this and this G10, and their team knew what we were talking about. You could, I mean, imagine a world where, even back to the contracting, if you send a price file, whether to a distributor or to a provider from a manufacturer, and you detail out, here's the unit of measures that this product comes in, not necessarily what we sell, but here's the unit of measures and here's the associated price with those. Wow, if I get that right at the contract, just imagine how quickly you'll get paid. So there's just so many benefits to both sides if we really embrace the standard and look for those opportunities.
I agree.
As far as the nomenclature, I agree with John. It needs to be used consistently. And one of the things, I guess, the cautions we had early on as we debated, you know, as we moved to unspec as the classification schema that we're using, and we keep our eye on Gmdn, we got mixed feelings as to how it was utilized. Was it utilized for a marketing purpose, or was it truly utilized to identify the product that would have meaning for all of us? And so I completely agree with John. It gets quite complicated and confusing when we adopt multiple standards.
Thank you very much. I mean, I don't see additional questions being posted, but just continuing with this conversation, I'd really love to learn, how do you foresee the immediate future now, having the European Union moving into a different direction, and how do you foresee a way to address that, or a way to prevent for unique systems to become multiple unique systems?
Certainly from a manufacturer perspective, this goes back to kind of the basis of my presentation today around adopting the IMDRF definition of UDI, so we do have one consistent definition, so we can more rapidly implement. Every time there's a variation, it's very different. It's very complicated for manufacturers to keep all the separate data. And I really would strongly encourage the adoption of IMDRF as defined for the UDI system. It means a lot, and it speeds up implementation. I think it's also a key to better data, et cetera. It's really important. And I think Abbott and certainly our various trade associations we belong to strongly advocate this. So it's been very much an advocacy effort on our part and our trade associations for consistency of adoption. The European Union, I think it's important to recognize, is doing a whole lot more than UDI. They have a much bigger idea, a bigger plan, of which UDI is actually a very small piece, and I think that should be remembered. And I think that's one of the reasons why they've been delayed. And I personally think they will continue to be delayed, because they have really laid out something quite grand versus just adopting UDI. It would seem to me that the adoption of just UDI is a big enough issue unto itself without adopting a much grander plan all at once. But that's me.
Yeah, and I just echoed John. It creates so much complication downstream because we are a global society and we have global manufacturers. We are impacted. Each one of us in our distinct countries will be impacted by these variations, and it increases our costs and really makes it so we can't take advantage and optimize what this could really do for us. So I echo, follow the standard.
And if I may say just one thing, particularly on the barcoding side, adopting of global standards for the identification and barcoding of products I cannot begin to underline how tremendously important that is to allow manufacturers to follow the rules of their issuing agency. Because if we don't, and we have country-specific requirements, we're talking about country-specific labeling. Country-specific labeling is expensive. It's also limits supply. And I think that's something that should be very much recognized. If we cannot move product around from country to country where there's country-specific labeling requirements, and which impacts our ability to provide what's needed and to respond to things that are unforeseen. So I think it's important. That's a really, really important one, and I'd like to underline that.
Perfect. Well, thank you very much. I think it has been really very beneficial for all of our audience now that we are in this really wonderful position to have both the regulators and the private sector from the entire region all together learning and sharing on this very relevant topic, mainly because of all the initiatives that are going on throughout the region and helping all of us understand the benefits and the disadvantages either of going through the direction on implementing standards as they are, instead of getting into some ideas of diverting from them and the consequences of that. Because at the end of the day, whatever diverges from a standard will definitely have the potential of a negative impact in regards of access to medical devices for the patients. And I think at the end of the day, it is what we are all here for, to make sure that patients have access in a timely manner to the devices that are required for their care. And we will continue to work, and we appreciate your help, and we look forward to continue developing efforts together, because as Cynthia was mentioning, it is a matter of education, and we really need to continue helping all of the relevant stakeholders in our sector to get the proper understanding on the pros and cons of going one direction or the other. So we really appreciate a lot all your inputs. And with this, then we will move to the second part of our session today. Thank you very much, and look forward for further collaboration.
Great, thank you very much.
Thank you very much.
Thank you. So Patty, now moving into you.
Thank you, Sandra. So moving on with our agenda, we're going to start presenting the experience of our regulators. I really appreciate and thank the availability of the regulators that we have to.
I don't know if it is only me, but Patty got frozen.
Yes, for me too.
Okay, just a second so we can check. So, okay, Patty.
Okay, sorry about that. Yeah, but my computer just decided to disconnect me while I was talking, so it's fun. So as I was saying, Elio joined Anvisa in 2015 and has served as business analyst, chief information security officer, and advisor. He's author of published papers in refereed journals, such as the Theoretical Computer Science, Discrete Applied Mathematics, and Algorithmica. So with that, Helio, the floor is yours. Thank you.
Thank you, Patricia. I'm going to share the screen. Just a sec. Are you able to see?
Yes, thank you.
So thank you for the introduction. I'm glad to be here again. Today, on behalf of Anvisa, I'm going to discuss the UDI system implementation here in our country. The next slides, I'm going to do the presentation in Portuguese, so I'm going to switch the language now. Bom, meu nome é Hélio Bonfim de Macedo Filho.
My name is Hélio Bonfim de Macedo Filho. I work as an advisor at Brazilian Health Regulatory Agency, Anvisa, in Brazil. And we're going to discuss the main aspects and the main lessons learned on the implementation of the UDI system in Brazil. As a summary of this presentation that we prepared, we're going to quickly discuss what we have on the UDI system that was very well defined by John's presentation. So we're going to talk about that framework. And after that, we're going to talk a little bit about the development of the UDI system regulation in Brazil, as well as the scope of the UDI system application in Brazil. About that, this is actually something that talks a little bit more about what happened through time. So we're going to discuss from now going forward the implementation of UDIs in Brazil and what we also have in terms of this implementation. Okay. So now moving on to the UDI system framework. John did a very good introduction, very precise introduction, and the concepts of the system. So the concepts actually come as something that is associated with the UDI system. And here I have a graphic showing of what John was able to introduce verbally. So here we have the UDI. Here specifically, we have a representation of the UDI using a quantification. So this is a barcode quantification. But the UDI system actually represents mainly three elements coming together. One is the development under globally accepted standards of the UDI. Then we have the affixing of the UDI on the device label and maybe on the device itself and all higher packaging levels. And then as a third element, we have the submission of the appropriate information to the UDI database from a specific jurisdiction. So these three elements, these are the elements that actually form the definition of the UDI system. And then we always like to stress, just so it's not confusing, we don't want to confuse the UDI system with the UDI database. Even though they have very similar names, they both have the system word or database word. One talks about how the UDI is going to happen, so the system of the UDI, and the other talks about the information system that is going to store elements related to medical devices, okay? Well, at Anvisa, we have divided our implementation of UDIs basically in two main elements. One is the UDI regulation itself. What are the rules of applications for UDI in Brazil? And the second one is when we are going to be able to work on building the information system that is going to store data related to medical devices, where they have UDIs, or specifically UDI, as a key to access data on medical devices. And the entire process involving this information, like data submission and eventually consultation by anyone.
So at this first moment, which we have already finished, is the development of regulation of UDI in Brazil. With that, we have implemented this first part of UDI in Brazil as part of our regulatory schedule from 2021 to 2023, and it was completely finished during the end of 2020 and the beginning of 2021. And then we launched the second part of launching of this UDI system, which is part of the strategic plan of Anvisa, specifically in the objective 3, which is to increase the access of Brazilian population to medical devices with safety and efficacy. Talking a little bit about the timeline of the development of the regulation for unique devices identification in Brazil, we have as a base document for all our regulations, the IMDRF documents. So the first document published at the end of December 2018 is the one that specifies the guidance of IMDRF. And the second one is the System Application Guide, finished in December 2018. So these two documents from 2013 and 2018 are a basis for Brazil and the key element of consultation to develop the regulation and also the implementation of UDI in Brazil. On July 7, 2020, UDI was announced as a priority for Anvisa because it was part of the strategic plans of the agency and was also part of the regulatory schedule of Anvisa from 2021 to 2023. And so here we start discussing important elements for the implementation of UDIs. And one of the main things that we discussed and we considered a success factor for the building of a regulation was the creation of a work group at Anvisa involving all of the areas at Anvisa that work with medical devices and the information technology areas. The main stakeholders and players affected by UDI implementation so that we all together could build a standardization that was also a fruitful environment for the implementation of UDI in Brazil. So we understand that this was very important, and that had also direct consequences of this working group that reinforced a better built, a more robust regulation built by Anvisa together with all the people that contributed. So we are increasingly adherent to the UDI regulation. So all players were also aligned to the same principle and were coherent with the UDI principles to build this UDI system in Brazil, and that was also globally harmonized. So we followed on to analyze the regulatory impact, and we were exempt from regulatory impact analysis due to a decree that not only is important for Anvisa, but for every regulatory authority in the country. And so we moved on to the public consultation, whose contributions also solidified the process. And then we had the normalization of the UDI and its publication on January 4th, 2022. So this is the RDC 591-2021, a resolution from the collegiate board. So now moving on to the second part of this development, we will work with the information system development that will include all data of medical devices connected to the UDI system and everything else related to this initiative. So now at the beginning of 2022, once we have UDI regulated in the country, we are now moving to a different process to developing the information system model, which is what was described by John as well. We have already reviewed our budget. We've already made the budget savings, and we are now working on the planning to include the UDI system as one of the projects to be carried out by Anvisa from now on. This whole process is standardized by the government of Brazil, and we have to follow the stages foreseen by the government. So all these stages are based on the Decree number 1 from 2019 that describe the stages to build an information system specific for UDIs. This is the stage where we're at right now. Then for the implementation, we have the essential elements that have to be submitted by either the manufacturer or the importer, and they, together with Anvisa, have evaluated the or have authorized through Anvisa their medical devices, and what is the scope of UDIs so that these elements are submitted to Anvisa and may be consulted by anyone. So this scope includes all medical devices marketed in Brazil, including products for in vitro diagnosis, with the exception of medical devices that are custom made and medical devices used for clinical investigation. Within that universe of medical devices, their information will have to be stored in the Brazilian UDI database, information about the device identification, contact, packaging, the nomenclature of the device. And I will not go into detail of each essential item, but I would like to highlight some specific issues. The first one is that during the whole standardization process, we converged increasingly more to adhere to the guidance of the IMDRF published at the end of 2013. So everything that is part of the standardization is included in the IMDRF document. Also, highlighting the nomenclature. One of the important things to be submitted to the database is the Gmdn of the device. The IMDRF document describes that this is an essential element. And for Anvisa as well is an innovative requirement, because previously we did not require the Gmdn, and from now on it will be mandatory. There are other mandatory elements or conditional. By conditional, I mean whenever it's applicable depending on the characteristics of the medical device. Here we can see the schedule for the implementation of the UDI in Brazil. So we have two different timelines. The first one is the position of the UDI on the device and on the external packaging, which we informally have been referring to the UDI in the real world. And in the second slide, we will see the implementation schedule of the elements to be sent to the database. And so to talk about the first timeline, according to the implementation schedule, from the publication of the RDC 591/2021 that happened on January 4th, 2022, so with that publication of that decree, we started to see the effects on domestic territory, and the industry will have to place the UDI according to the risk levels of the medical devices. So level 4, class 4 is the highest risk, and class 1 are the lowest risk. And so we follow that scale. The idea is that class 4 medical devices have to have the UDI on their labels on superior packaging within 2.5 years from the publication of the RDC, and other classes follow 3, 4, and 6 years after the publication of the decree. We have a specific case that when the medical device is reused and the UDI is placed on the device itself, then the deadline for that device will have an extra 2 years, from the previous deadline. So if it's a medical device with a class 3 and the UDI is placed on the device itself, then they will have 5 years to have the UDI on the product and on the external packaging. And the deadline to the submission of UDI in the database, once we have the UDI database, that deadline is counted from when the system will be able to receive data regarding medical devices where the UDIs will be placed. So this is very similar to the previous timeline, but now we count the deadline. We count the deadline from the availability of the system, when the information system is made available. So to finalize, I would like to talk about lessons learned in the process and what we will be implementing in the short, medium, and long term. The first thing is that implementation of UDI in Brazil has been very, very quick considering national parameters, and we have several success factors for that. The first one, and the main one, is the support of the main stakeholders and senior managers of the agency that have contributed a lot so that we could produce results in a very quick manner.
The work group itself had an essential participation of all the main stakeholders, and we had we basically had 10 institutions and associations that involve other institutions and associations actively participating in this process. Also, we understood that we had a high success rate on standardization, specifically because what we realized is that the pandemic that affected the entire world, and in that case, a lot of initiatives didn't affect the time and schedule we had for the regulation of the UDI system in Brazil. And we have a lot of challenges ahead because the main one is the development of the database, because we don't know an off-the-shelf software that is able to support the specifications of information systems that we need for different countries. We know that most countries are developing customized software, so that's possibly what we're going to do here. And Brazil is also going through a very high devaluation of local currency. During the pandemic, our local currency has devalued in over 50%. And also, the qualified workforce seeks remote work abroad because of that. And in this case, we may be looking at a more fragile market of information systems to build information systems in our country. So that's it. Thank you so much for the opportunity. And it's always a pleasure to participate in these events. And they bring a lot of elements that are helpful in the implementation process for UDIs.
Muchas gracias, Elio, por tu presentación. A continuación, tenemos la presentación.
Thank you very much, Elio, for your presentation. We now have the presentation from Javier Quintero. He's a chemical engineer at the Regulatory Agency for Control and Sanitary Surveillance in Ecuador since 2017. He's worked there in the development of sanitary standards for drugs, medical devices, and other products of use and human consumption. He has experience in best manufacturing practices for pharmaceutical laboratories and evaluation of processes and ISO 9001 quality systems and other systems. He has led continuous improvement projects and processes, and he's always also be consultant in different topics. So thank you very much, Javier Quintero, for participating here, and you pass the floor. Good morning. Thank you, Patricia, and thank you to all the participants. For me, it's an honor to be invited this morning to this event. I'm going to share my presentation in a moment, the one that I have for all of you. And I want to talk about the history of these regulations, how it evolved in the case of Ecuador, the experience we've had in traceability and marking for medical devices, especially for medications. But I'm going to focus on medical devices specifically because it's what we're talking about. You know, we're talking about the UDI, about this unique identifier for all of these medical devices. So if we can go to the presentation. Well, when we started with this path, we based the implementation of these standards under a certain premise. And I want to be clear on something. In Ecuador, it was the first time that a project of this size was being implemented. And this project was considering many changes, especially at the public procurement level of drugs. And this also gave place to many reforms and many of the regulations that had to do with the acquisitions. These was a product, medical products and medical devices, so that we could create a traceability and identification system for all drugs and strategic assets that were called like that at that moment, part of which included medical devices. We understood strategic goods, all of those products, devices, and inputs that are necessary for the sanitary or the health authorities to be used in the different hospitals for health purposes. So through a presidential decree, which was Decree 1023 of 2020, they issued these regulations where they are demanding the traceability for medical devices and for medications. In the case of medical devices, for the development of the ARCSA DE 030 resolution, which is the resolution that was based and that talked about the technical aspects of the adoption of this unique identification for all of these devices. And it basically included a traceability system and a tracking system that was full track and place from the moment the product arrived in the import, keeping the same number that the manufacturer or the code that the manufacturer had appointed abroad. And in the case of domestic manufacturing, it would have to receive a specific code so that traceability could be possible. We considered in this resolution that the codification had to be done through a standard system, through a worldwide standard. That is why we adopted GS1 to be able to work with this identification standard and to minimize as much as possible any possible impact in the marking and traceability of the devices. This is because over 90% of all the devices that we have in our country are imported, so that's why it was important. So this way we were tracking in all of the distribution chain and the manufacturing chain, the products going from the distribution of the product to hospitals, pharmacies and hospitals in general, all the way to getting to the patient in the doctor's office. And all of this was input in a database based on the concept that we had at the moment. We included all of this in a database and an information system that had to be developed in real time so as to determine all the movements and be able to do the monitoring and the control of the product at any given moment of the chain. So this is what in general was included in ARCSA's resolution. That was a resolution 030 and it was issued in 2020. And I want to highlight that date because ARCSA's resolution is born because of the Executive Decree 1033 of the year 2020. And these ARCSA resolutions was enforced in November of 2020 of that same year. And so these are really critical and important dates because we were undergoing a worldwide pandemic. It's very important because with the pandemic, priorities changed and they started becoming an issue for the efficient implementation of these regulations. In the technical area, well, we were basically working with the guidelines provided by the International Forum, the IMDF. Through its guides, we reviewed them, reviewed the ones that they published in 2019. And we also worked together with GS1. So at the beginning of the formulation and the assessment of these regulations, as I said, it was the first time that we had this sort of experience in Ecuador, and we had to meet several entities. We had to meet several stakeholders from GS1 and from other regulatory agencies that existed at a local level, a regional level, and those who had experience and had done work on traceability and marking of the devices so that we could begin developing regulations that will follow international standards. And this way, we could avoid any negative impact or other type of issues because of shortages in supply, or because of procurement issues, because there were different regional systems, or because we had our own proprietary systems. So, I mean, that was one of the main ideas we had at the beginning, to have a proprietary system. But after assessing the impact and the analysis of the regulatory impact, we decided that the best way was to work, to follow and to work the technical guides of the IMDRF regarding medical devices and the UDI, this unique identification, device identification. As we've seen in other presentations, this is formed by two different sections. We have the device identifier in one part, which is a fixed part, and then we have the variable part, that is the product identifier, and that is mainly identified with the serial number, the lot number, the expiration date. And I mean, we followed the GS1 standard that we started before. Regarding the expected benefits of this UDI and of the traceability project, I think that we were all very clear on what the benefits were going to be for the different stakeholders in the chain, both for the health authorities. They had advantages because they had the inventory more visible, and our objective was to improve the surveillance and the surveillance in the market of all of these devices. Another advantage for the health authorities was that they could have a harmonization of international standards versus the nomenclature used for the different medical devices. You know, that there's a different way, or that they might have had a different name throughout the value chain, and even a different name in different providers and suppliers. So to have this harmonization and be able to identify these devices was the best thing. And we also wanted to fight against counterfeiting. We had that was one of our main objectives by doing this, and to reduce any losses or inventory deterioration. In the case of the regulated ones, we had a better planning of supplies. We also had reacted to any quality problems to have a much more efficient recall process. We had an improvement in the inventory and the supply chains. At the hospitals, the benefits were that they would have an accurate identification of the product, and they would have timely information of the product, which was really important to be able to have this follow-up, especially when talking about safety of the patient. There was improvement also in the planning and acquisition, as well as in the management of all the adverse reports of each one of the products. The main point, or the main objective for patients, was that we wanted to improve the safety of that patient, regarding how to the control of the dispensing, and to make sure that the marking was a correct marking, so as to make sure that the device can get to any consultation with the patient in the safest way possible, and that we can have a traceability of the whole history of that product per se. So that way we could have information for treatments with the data analysis that would be created by applying the traceability and these standards. However, as time went by, and let me talk about the dates again, because we just started this in November of 2020, but we found ourselves with certain critical areas in the application of these standards. When we talked about traceability, we were talking about the creation of data throughout the distribution chain. During the capturing of the data with the devices that we had to capture them, we started creating all of this information, but this had to be uploaded to a database. Thus, this was like the first pain point, who's going to manage this database? These were things that were not clear at that moment. And the database management had to be one of the priorities of the health authorities. Another pain point was a clear definition of the scope of the project. I think that many times we lost a lot of time trying to define where the project would come to. You know, we identified the projects that were developed by the state through the Ministry of Health. And so this had to cover all the national market for all the products that are imported and are presented or given through the health unit. So then the universe of things increased. At the end of the day, the provision stipulated that we would manage the scope. The scope would be managed for all the different products, and that made everything a lot more complicated, you know, especially when we had the reduction. So we had a universe of a huge amount of products that represented a challenge for the marking, the serialization, and the future implementation of the application terms. A clear recommendation that was established was that the times for application are not that long. So that's why in order to apply the standards, we would have 2 years or 24 months to be able to apply it. And so what we've seen, and by talking to other authorities, regional authorities, what we've understood is that there are timelines that have to be much more extended, that cover up to 3, 4, 5 years, even 6 years. And so this was another important part to take into consideration for this project to be successful. We should start with a shorter list of products to be able to comply with the 24 months that was originally included in the regulation. You know, that would be the best thing so that we can start scaling up and increasing the list of product and comply with the necessary objectives. The capturing technology and the IT systems was something necessary because we needed all the health authorities to have these type of devices. That was one of the main obstacles, you know, the technology aspect, because each system had their own IT system, their own inventory management system. And so we needed to identify a complete system for the capturing and the use of the UDI technology and to have the traceability technology, and that became a lot more complex. The impact in delivering products that will comply with the regulations was another one of the obstacles, because over 90% of the products are imported. Thus, up to 2020 or the end of 2020, by the end of 2020, only 50% of domestic suppliers could provide and comply with all of these rules and regulations to work together with the serialization and the traceability aspects. In 2021, because of a private sector initiative and initiative of GS1, we started a pilot test. We thought about developing this pilot test to see the maturity of the implementation and of the system that we had. And we had 17 companies participating. We had around 129 devices evaluated. 102 were not implantable and 27 were. The study or the pilot test came to the conclusion that ES1 recommends us to align to the recommendations of the IMDRF. The variability regarding the compliance of certain points that the GS1 had was another one of the observations that came about from this report. I think that regarding the marking, you know, I think that there was a lot of differences when implementing these shorter terms to do so, and that created a very complex situation, you know, regarding the identification and the knowledge that is required to be able to implement the UDI technology in all the different stakeholders in the chain, you know, not only the suppliers, but also all the different entities, the regulatory entities, and everybody involved. And this was one of the main obstacles that had to be considered. The results also mentioned that 88% of all the products comply with the information requirements recommended by the IMDRF, and 0% of them complied with the requirement of identification at the logistic units level under the certain standard. 73% comply with the traceability code that was indicated and basically was defined through the data matrix codification or the barcode under the GS1 standard, and only 45.4% complied with this, and 58.8% of all the control points, compulsory control points were for traceability were complied with after doing this pilot. So this showed that there was a lot still to be worked on and to be complied with, regarding this decree. And so on December 28th of 2021, the presidency office presented the decree 1023 of 2020, including the traceability for any procurement processes carried out by the hospitals, as well as the traceability of all the medical devices is eliminated at that moment. So this also represented many lessons learned and left many experiences. First, a lot of leadership and knowledge aspects. The objective why this project was born was because we wanted to keep an identification system to improve public procurement processes. The UDI for the health authorities had a different meaning and a different scope, because for them, they wanted to improve the identification to guarantee the safety and the care of the patient. So in this path, we found that we didn't have clear objectives, really clear objectives to be able to be successful in the implementation of this project. Another important lesson learned was that of communication between stakeholders and project leaders. The health decisions have to be made by those who know about the health uses. The procurement decision should be taken by those experts in procurement processes, and technology decisions should be made by IT experts, and all of those have to be connected through a whole system, a holistic system, a teamwork system, and a communication system that allows us to be very coordinated and to know where that project needs to be directed to. We consider that the terms have to be much more extended so as to be able to implement the UDI systems. These terms should include the pilots, the periodic recovery of data that has to be done, include lists that are shorter at that moment so that it could be fully implemented, and to be able to scale up that project so that little by little we can be integrating and correcting any of the mistakes made so that we can improve the implementation processes. It's important to have institutional strengthening also so that we can enhance the training and the knowledge that we have in all of these topics. Regarding the project leaders, well, we need to establish the necessary priorities. I think that we cannot work with a large amount of elements or devices. We need to start working with those products that are the ones that create the most amount of problems in their implementation in all the Republic. We needed to check the cost-related topics, those that have the main losses or that create more losses, those products that are subject to counterfeiting or any other effect, things that need to be considered when prioritizing the identification and serialization of the products. And lastly, we need to learn from the experiences of others. That's very important because this also minimizes costs. There are countries that have already started this journey this traceability journey or this identification journey and marking journey through the UDI systems and the GS1 systems. And what I consider is that the technological aspect is already there. It already exists. So what we have to do is we need to improve that. We need to improve that and to learn from the mistakes that have been made to understand that not everything is technology related and that these projects have a huge impact on people, specifically on people who are behind this, because they are the ones who need to work on this and to develop everything. To understand that some win and others are going to lose, it's very important to be successful, and it's good to be able to start building an identification system that will help us to improve the quality and the safety of all the products, always focusing on patient benefit. So thank you very much for this invitation once again, and I'm ready for any questions you might have. Thank you very much.
Thank you, Javier, for the
Thank you, Javier, for this
presentation.
presentation.
And thank you for
We
the
thank you for your
participation.
participation
And
in
we
this
hope
webinar,
to receive many
and we hope we
questions.
can get many questions on your
So I'd like to
presentation.
take
I just want
advantage
to
of
tell you
reminding
that
you, each and every one of you, to put your questions on the bottom part of your screen. And so we can see this Q&A session. It is not necessary, and you don't have to include all the sessions. Nevertheless, as you start putting them up there, they are going to be responded. So let's move to the next one. And it is Ira Kandui.
Programs 3, DRP3, in the Office of Regulatory Programs, Office of Product Evaluation and Quality, OPEC, in CDRH. She is actively engaged in leading UDI program implementation efforts for OPEC. Indira joined the FDA in the year 2000 as an IT specialist. She later became chief of the Information Analysis Branch, where she initiated and led the successful launch of the Electronic Medical Device Reporting Program. Indira worked at the Health Resources and Services Administration, HRSA, as chief of the Compliance Branch in the Division of Practitioner Data Banks. In 2011, Indira returned to CDRH to work on the Unique Device Identification Program and served as a program manager for the Global team. When she left to work for me, she worked as the business process manager for the FDA ACE system, which receives and processes FDA-regulated imported products. Prior to her work with FDA, Indira's work experience includes working as a software engineer at Verizon, medical technologist at 2 community hospital laboratories. Indira earned a Bachelor in Sciences in Clinical Laboratory Science from the University of Nevada in Reno, and a Master of Sciences in Information Systems and Accounting from Virginia Polytechnic Institute and State University. So with that, Indira, please, you have the floor.
Thank you very much. It's my pleasure to be here. Let me share my screen. I hope you're able to see. Can I get a quick check to make sure you can see my screen? Perfect.
Yes.
Great. Well, greetings, everyone. It's an absolute pleasure to be part of this forum and to present what the US FDA UDI implementation, where it is today, and also share some lessons learned. It's been fantastic to hear experiences from implementers like Cynthia from the hospital side perspective and John from the industry implementation perspective, and also the other regulatory agencies which are beginning their long journey with UDI. As far as where we are, it has been a very long and fruitful journey for us. And our regulation came out in September 2013. That is when the UDI final rule was published in the United States. And so we are almost close to, sort of reaching our initial goal that we set for ourselves, which is in September 2022, all devices that are required by that regulation that came out in 2013 to have a UDI on the label of the device and have information submitted to the Global Unique Device Identification Database, or what we call the GUD ID, will be completed by September 2022, unless we have granted an exception for the requirement through some means. So where are we today? If you look at this graph, we have more than 3.2 million device identification records in our database. This contains, you see the spikes here in this graph. Each time we had a compliance date, similar to the other regulatory bodies we heard this morning from Ecuador and Brazil. We also chose to implement this as a risk-based compliance deadline. So class 3, which is the highest risk devices in the United States, went first, followed by implants, life-sustaining and life-supporting devices in September 2015, and then class 2, which is September 2016, and now we are almost getting there with the class 1 devices. So there is a spike and the data has been coming in, and of course the other key requirement, which is the UDI has to be on the label of the device, has also been complied by all the required labelers or the manufacturers. And when we look further at these 3.2 million records, most of the records are class 2 devices, as you can see the distribution here, and 35% of those records are associated with implantable devices. And again, here just shows you the different medical specialties. These are based on Usfda product codes that we use. And again, orthopedic devices have the largest amount of device identification records, followed by general and plastic surgery, dental, and cardiovascular, and the others, as you see, just a different breakdown. This is a word cloud, if you will, just kind of shows you the different product codes that are represented. Again, fixation seems to be the biggest one, matches what I showed you in the other slide with the orthopedic devices, just a different way to view the data. And all of these records, the 3.2 million records, are available for access by anyone across the globe on Access Good ID, which is our public portal. It's free of cost. We update the data daily as we get it into the Usfda database. Daily updates, the next day the data will be updated on Access Good ID portal. You can search, download devices, and you can also, we have useful APIs. I think Cynthia mentioned the APIs. They are widely used, and I'll show you some statistics about that as well. And we're always open to additional ways to enhance this public access portal to make it useful for our users. This is some usage data from this December 2021 of Access Good ID. You see in December, there were close to 45,000 users, and the access was all across the globe, with India rating the second highest after United States users. And if you look at the download and API usage, there were almost 1,500 download events for the system. And those APIs, you see there were more than 23 million hits on the lookup DI. Basically what this does is, if you have a device identifier or a UDI, you can essentially, pass that to call the API with that device identifier, and the system will return all the device identification information for that given UDI. The parse UDI is another API we have, which allows you to take the entire UDI string and split it up into the device identifier and production identifier pieces. The implant list API essentially gives you a list of all the implants that are in the device identification database. So now I want to move on to talking and sharing with you some of the lessons learned for the US FDA over the past many years that we've been working on this. The first thing is what we've heard from stakeholders, specifically industry stakeholders, is please harmonize, right? Strive to harmonize. And it was great to hear similar sentiment from our other colleagues in other regulatory bodies today. Also leveraging the IMDRF work. Great work has been done in IMDRF. The US FDA was the first one to put out the regulation, but we've been actively engaged in IMDRF work. And last week, when we had this session, one of the webinar, my colleague Michael Simpson gave a presentation on the fantastic work and all the body of work that IMDRF has produced in this UDI topic. So definitely please leverage that. And the other thing we've learned is it is important to establish realistic and achievable deadlines for both industry and the regulatory body. We heard some of that again today. The COVID-19 pandemic has definitely taken the public health focus away from certain projects in having to, reallocate resources to handle that. And that was similar to us as well. So we've had to move some of the deadlines we had established for UDI. But even before the pandemic hit us, we still moved some of the compliance deadlines we had for various reasons. And some of it was internal challenges that we faced in implementing the UDI system, and some of it was also based on requests from stakeholders. So it's important to look at the deadlines you have. As fantastic as it is for all of us to want to get there as soon as we can, some realistic and achievable deadlines must be considered. And the policy and technical decisions that we put in place, it's important to consider how this data will be used in real world. And we had several challenges, whether we were talking about how UDI needs to be placed in device kits, device systems, and also software as a medical device. So these were unique device situations that we had to consider. And what helped us was to think about how how this information will be used in the supply chain in the real world before we arrived at policy decisions. So that's important to keep in mind. And also, you need to think about a compliance policy that is workable, so that the data in the database is maintained and kept up to date. Things change, and how can we encourage that the data stays updated? And that's definitely a challenge for us. We haven't figured out a fantastic solution for that yet. So I'm happy to hear great ideas if anybody has, or work with other collaborators. But that is something that definitely I would encourage anyone thinking about UDI regulation or working on starting this UDI system to definitely consider as a key point. So moving again to the database, again, it's important to harmonize, and key to that is to establish clear definitions for data elements. So we can all choose any data element. There are multiple ways to look at, very simple things, right? For example, what do you want to call brand name? Brand name can be defined in so many ways. Similarly, device description. Is it the intended use? Is it the approved regulatory use? So sometimes it's the slight interpretations in what something is called by one regulatory agency versus another makes a big difference. So the data in the US FDA database may not match the data in a different regulatory body's database just because of the difference in interpretation, even though we are calling it the same thing. So in that perspective, IMDRF is a great resource to utilize and harmonize on. Try to use standard list of values where possible. This is, almost basic 101 for database design. And what we also found is generalized standard list of values may not work for every single data element. For example, device size. We find that general categories of device size are only so helpful. But if you develop specific sizes for cardiac devices, they would be different from device sizes, for example, for orthopedic devices. So it might help to think about device areas because devices tend to be inherently complex. That is something that we've learned. We still have a lot of work to do in this regard. Yes and no drop downs versus checkboxes. We designed our database with a lot of checkboxes. If you check the box, it means it's a yes. If you don't check it, it means a no. But that's not as explicit as actually having a yes, no, or NA, maybe a not applicable. Not applicable might reduce some of the ambiguity in how data is responded to and how data is provided by the users. Also consider how you plan to use the data as you develop the system. It's important to have pilot projects. When we started the database GoodID, we did not require catalog number. So catalog number was not a required data element. However, what we realized is since we were the first out the door with the UDI regulation, until the the community, the ecosystem came to a point where everybody was using UDI, catalog numbers were still used as the norm. And therefore, not having catalog number made it difficult for hospital systems to use our data. So it's important to think about how will the data be used and where is the ecosystem where you are as you design this database and put in business validation rules. Set up efficient and easy processes. Again, as I said, data update is critical. This data is not useful unless it's kept updated. So make sure you have a policy, compliance policy to get manufacturers to keep the data updated and also make it easy for the update as well. And again, have strong data validation rules. Stakeholder outreach and education. This is very, very important. Reach out early and often. We have worked very collaboratively with stakeholders across the UDI ecosystem. This includes hospital systems. This includes manufacturers. For example, John and his team were actively engaged very early on, reviewing all the data definitions for the GoodID system and asking us amazing questions, which helped us further clarify those definitions and really make them as precise as we possibly can with English language, right? So it was really helpful to have that collaboration. And we've also worked with hospital systems like, for example, Cynthia's Intermountain, just to understand the challenges they face in using the system and how can we make things better on our side. And leverage external stakeholders to multiply the common messages. So when Cynthia goes and talks about the importance of UDI, or when John does, it helps, what we are trying to achieve as well. So it's always helpful to have those connections. And we've also found having user communities and groups pulled together to think about UDI implementation highly, highly beneficial. And as a program, as a regulatory body, you may want to think about how to staff for cyclical ups and downs. As I showed you that graph where the number of records went up, each one of those spikes resulted in a tremendous workload on the staff in the USFDA. And it was a challenge to maintain the questions that were coming from external users and us being able to respond to that and making sure the system was functioning. So something to think about as you hit your compliance dates. As far as adoption, I think you need to begin early, right at the beginning, if that makes any sense. We didn't get, in hindsight, right, thinking about what we could have done better. We probably should have kicked off some adoption project earlier than we did. I think there is a lot of lessons learned that we've learned over time. Had we kicked off those projects sooner or coordinated them so they almost went parallel to the UDI implementation of the rule, I think it may have been served us a little better than it did. So begin your UDI use and value projects throughout the supply chain and point of care, right as you kick off getting the data into the system and having those UDIs on the label. And it's important to document and share those lessons learned and talk about the benefits of UDI. And as John mentioned, this is really not about cost savings or anything. It's more about patient safety. And sometimes those messages are hard to get across, especially for people who are only focused on the dollar values. So it's important to start this early and keep at it and keep at it and keep at it so the message really percolates. Support and encourage. I talked about this learning communities and user group that has been huge in the US for bringing together a group of like-minded people who are looking for UDI implementation ideas and looking for ways to address the challenges to advance patient safety needs. And of course, you have to establish processes and prioritize the lessons learned from all of these projects and figure out what do you want to work on? We have a ton of lessons learned from the US UDI implementation experience. Honestly, it's a challenge to prioritize resources and say, I will work on this versus this. So good to think about that as well. So really where we are in the US is we've made a good, great start, but we still have a long way to go to really get to where the intent of the UDI rule is realized. The intent is adequate identification throughout the distribution, all the way to patient use. And, we're making progress. We now have a centralized repository of device identification. As I mentioned, by September 2022, all devices in the US, unless they're accepted as per the UDI rule, should have the label of the device to have a UDI and data in the system. And now we are looking to move this along to look at, UDI in all regulatory data. How can we leverage that for internal decision-making, regulatory decision-making, and looking to promote UDI as a real-world data source, and also moving forward, continuing to promote patient safety needs and leveraging UDI to promote patient safety goals. Here are some UDI program resources, and please leverage them. The Access Good ID is a great source. All the device data is available to you, and you have our contacts from the US FDA. Please reach out. We're happy to share and work with you and to promote UDI implementation. Thank you. That's my talk for the day. I turn it back over.
Thank you, Indira, for your presentation. And para cerrar nuestra sesión de reguladores.
And in order to continue, I'd like to introduce Oscar Marin Diaz. He's a physical engineer in medical physics, and he's a coordinator of the medical device group and ionizing on in the area. And he's part of the social protection in Colombia for the last 5 years. Oscar, we'd like to give the floor. Good morning, everyone. And the presentation that we have today is a presentation that is designed for an audience. And here we are going to talk about some for the medical audience. So we're going to mention others, some points that I'm going to go through very quickly because they're like more for a medical audience. And the idea is to give you a regulatory context where does our regulation comes up with that we are going to be mentioning, and what do we want to achieve with the semantics for medical devices. And in the progress that we have to decrease laws that the Ministry of Health and Social Protection has to develop guidelines to classify medical devices in order to have sanitary surveillance and epidemiological surveillance. The second law says that we must implement a we must standardize semantically in order to have social security on health. This general health system is a very large system in Colombia that implies several assurance models, and they are the main source of health provision in Colombia. And from these norms or regulations, we have two resolutions from the year 2013. And what do we want to achieve specifically through the implementation of the semantic standard of medical devices? And these are some points. The first one is identification and classification of medical devices. We have to say this is the device without any mistakes, managing and supply, acquisition and use of medical devices. These, of course, according to the ministry, is very, very important because we have to know and have ideas and know how do medical devices move within the supply chain and marketing and expense management. And this point is how do we manage expenses with the health service providers that are hospitals, clinics, and health centers, and how we have this process, information exchange among different government entities. In our case, we as a Ministry of Health, I will talk to you about this point. However, the Ministry of Health doesn't pay. Another entity is the one that pays. So that's why we need information exchange. Traceability. Traceability is how the medical devices are entering into the country, and as soon as they go into the country, then they are part of the biomedical device and price regulation. We as Ministry of Health have and are integrated a commission that is dedicated to see if to make sure that some devices can come with the price controls and others are with the surveillance. For the Ministry of Health, this is very difficult to have a price regulation because we don't know which are the medical devices that come in, but this is the process that we currently follow. What is the current problem? What happens at present? What are our current problems? There are different medical devices with different denominations and with different prices in the market. And this is, for example, what happens at present, because medical devices have to go into request their sanitary record, and in this process they have different names, but they end up being the same device. So we have to call it X-ray equipment plus blah blah blah. And this device ends up being just a device for radiology. So the offer is different, but they have different endings, even if it's an X-ray device. So this ends when the procedure, the medical procedure is done. In the case of osteosynthesis material or instruments that end up being charged to the health system with certain prices. So this is kind of a small parenthesis of how does our health system works in Colombia. The procedure is recovered and is charged in the system to an entity that is called ADRE, and there we can share the information with ADRE. So the truth is that this collection process, we want it to be as transparent as possible, charging for a generic medical device and not that was on like it has an additional clause that would have an additional price, and that we know exactly what is the medical device that has been charged and not a medical device that apparently has other different features. So there's things that happen that are in that recovery process and that are being recovered and that are not associated to the medical device, and they are included, and that is why they have a different price. And the groupings or that they are not, the medical devices are not grouped properly. So within the medical device, we have to check those that are at risk. So the idea is that when I recover when I do a grouping of certain medical devices, I only group those medical devices that are have the same risk. So what is our proposal for this implementation process? So in my case, again, I want to talk about the semantic standard. Here we're talking about the determination of the term. I call all the medical devices with a generic term. So that we all would know it, that is a titanium screw, like this medical device, FR 219456, aside from the codification, but there is a codification. We give it a number, and we give it letters and number for that. So for us, it's titanium screw, and we can give EPR 9470. And depending on the key, they're going to have the same device. And that is it is a screwed screw. So in order to choose the nomenclature, in order to choose the terms, before there were a lot of terms, or there were a lot of nomenclatures in the world. However, the ones that the Ministry of Health evaluated according to our country requirements is the Gmdn. The Gmdn is giving us this information, and we are going to be working with the Ministry of Health according to the nomenclature of the Gmdn, and they have up to 200 codes for each medical device. And here I'm going to pass this very quickly because or the system, what the system does is that the system has a code with the information that is telling us this is a medical device, is going to be assigned to a 7 characters to identify the manufacturer and 6 characters to understand the product references. And what we are going to end up having is clinical attributes within the implementation process. As I said to you before, the idea is to be involved in the service provision, in the supply chain, and in the price regulation. So there's going to be other codes associated in the country, such as the CUPS, that is a health a unique code procedures, that this code has been used for certain things. So for example, we have other attributes within the system that are the use units, the where the storage conditions, the packaging, the risk, also the brand and the manufacturer. So how do we generate the IDM? The IDM is our identification system. The manufacturer requests from the Gmdn the regulatory information, and they deliver a code. This is not a public code. And what they request from in VIMA, that is our health agency, like your FDA, they would generate and they would encrypt the code that has, on the one hand, the basic information of the Gmdn, of the term, the generic term, plus the manufacturing code, plus the product reference code and the product specifications. And that is going to be shared and by an information health system that the Ministry of Health has, that is called SIS-PRO. So for each person receives information, analyzes information. So in our case, at the moment, we have been checking that the manufacturer has to requests from the Gmdn agency for the codes, and these codes depend if this is a company that has more than 200 devices, so it's going to have what this process, what they'll do is they're going to have a request before INVIMA, the generation of the codes, and then they have to adjust to the institutional information systems. They have to include the nomenclature that we have been designing. And a very important point here is that at par with other agencies, we are developing the electronic billing in health, and the electronic billing is going to allow the implementation of these type of nomenclatures and standards. So we have some first phases, and these phases are going to be applied according to the risk classification that we have for the semantic standard. So the first of them is that there's going to be around 5,000 sanitary records for 2B and 3, and this process would also be for in vitro diagnosis reagents and 3,000 references for them to start their implementation and load information. Phase 2, we're talking about the fact that we're using this device and the implementation of this system for insurers and service providers and for the industry, and then we would be paying for these recoveries. And in the third phase, we would be talking about the risks to AN1 that are low risk, and this standardization is going to be used in the recoveries or recharges, and so that they use in case of adverse events or counterfeiting or others, we're going to do, for example, proper surveillance for this standard. What is the timeline in order to implement the standard? We have processes that are going to start from the moment you publish the rules and regulations, and so these are for this resolution. So at the beginning, we would have a year in order to do some adjustments inside the sanitary, to look at these numbers and look at these codes. We have to socialize with the users, and after that we're going to start with the target of the medical devices that are going to be requested, and this is a process that is going to be ready in 2 years. And the people that they have their sanitary record would start with uploading the ones that are already in effect. At the end of year 4, we're going to start with the use of IPS. And so now, at the end of the 4th year, we're going to start with what has to do with issuing other administrative acts, like for price control, for traceability, and for other goals that we had said and mentioned before. Now, how are we going to comply with the resolution goals, the resolution 2535, and how do we do the identification and classification of DMs? This is going to be done between the 2nd and 4th year. We're going to manage supply, acquisition, use, expense management, information exchange around the 4th year. And as of the 5th year, we'll be talking about price and traceability. And this is kind of a summary of what I wanted to show you right now. However, there is one point that is not in the presentation because it's something that we're managing internally, and these are the working process that of this year, and is the use of the UID. And this is a proposal done, and this is started last year. This was a pilot as of the agency that issued UID in Colombia, and now the Association of Industrials that is going to do a pilot to see how it works. So the idea here is to use these processes that I showed you together with the UID in Colombia. So we still do not have any phases. We still do not have any structure of how this is going to be done. And this is how it's going to be working in the country. And with that, I finish. Thank you so much. Thank you, Oscar, for your presentation. And next, we are going to start with the Q&A session. And I'm going to allow myself start with two questions that are hanging in the air since last year with our introduction seminar, where we were not able to give an answer because of time restrictions. The first one was
implementation of UDI. So the answer is yes. UDI has allowed us to identify medical devices related to potential adverse events and determine the scope of impact. For example, during a recall situation, it helped determine products impacted by a manufacturing issue that were imported into the US, but also products that were manufactured during the same time and distributed to other countries. The second question is, does the FDA use Gmdn definitions only for the good ID? The answer is yes. So additional to these questions, we have already received some other questions in our chat box that were already answered. So I'm gonna just go through them very quickly because we want to everybody in the that it's participating here can learn about these questions. So the first one was directed to Anvisa, and they are asking, is it on system level we are to assign UDIs, or do we also need to assign UDIs to accessories and components? This differs per country who has are about to implement UDI today. The response is, you need to assign UDIs to accessories if these accessories are going to be sold as medical devices alone. Otherwise, UDIs is assigned to the medical device in which the accessory is attached to. We also have a second question that was directed to Ecuador, and it says, understanding all the challenges and the decisions to revoke the resolution, but as well all the benefits of UDI, is there any plan to implement it in the long term? And the answer is, at the time the presidential decree revokes all the resolutions or normativity included the one that was issued by AXA on traceability. We're waiting that from the central government, they issued the guidelines to work in a project related with traceability and the identification of medical devices. So these are the questions that were already replied in written. And I know that Sandra has another question. Could you, Sandra, pose your question, please?
Yes, sure. Can I voice it?
Yes.
Perfect. Thank you very much. And I will do it in Spanish better. Son un par de
These are a couple of questions for Ecuador and for Javier. First of all, Javier, thank you so much for sharing, because I think that it's been quite valuable to get to know all the experience, all the steps, all the challenges that you lived throughout the development of all of these different regulations and the moment where you're at, where many of these things were canceled. And in that sense, in order to according to the following stages about this process and about the continuity or not of the implementation of UBI in Ecuador. And also taking advantage of Javier's positions as the head of rules and regulations, have you considered for the next steps and as part of the commercial agreement that entered in effect between the United States and Ecuador as part of the trade agreement and implementation within their operation system? Have you taken into account the implementation of good regulatory practices now that is a legal obligation as of this trade agreement? Thank you. Thank you so much. And Ecuador has started some regulatory practices, and within the regulatory impact of the regulatory analysis, we're going to follow this process and impacts at an application level. So we in our hands have, and we have very clear that all the norms have to be socialized. We have to work on them according to the different players and that are going to be impacted. So in the case of Arce, we suggest that we recommend for these norms to be born up down, but to be transversal at all the players levels, and also regarding importers that have to work jointly with manufacturers in the implementation of these types of codes. And the unique UDI identifier is a language that becomes universal, and we cannot make ourselves or isolate ourselves from the rest of the world, having systems or codes that are unique only for Ecuador, being such a small country. And even more so, this could have an important impact in the generation of supply. If I want to buy, for example, product, I want to acquire product from other countries, that the manufacturer precise medical devices that already have this codes, or countries that have great surveillance like the FDA in the United States or the European one, where they have established terms and defined for the application of these marking systems. So I also feel it's important to abide by these systems, but the World Convention is a basis, and the creation of our own system with our own codification is not viable. I think that we should apply the world marks and the IMDRF codes, as well as the ones from the rest of the regulatory entities throughout the world. So that is the path that we should follow in order to, regarding our regulatory implementation.
Muchas gracias, Javier. La siguiente pregunta que tenemos en nuestra cajita.
Thank you, Javier. And our next question is from Lomoloy, and this is for Oscar Marin. They're asking if the codes that you were mentioning, are they expected to be placed on the labels of the medical devices by the industry? Well, not at the beginning, not as a principle. What happens with labeling? Well, labeling has its standard that of Decree 4225. And so to start with, there is no request regarding the labeling, but it's something that we would have to cover in another standard, what is happening or what is expected to happen with this regulation is to assign the codes, with the sanitary registry and the use as based on the regulations and processes that we have. So just to begin with, we do not have any instruction of placing the code as part of the label. Okay, thank you very much. Our next question, also for Oscar, is from Marisol Sanchez, and the question is, the semantic standard for Colombia is going to be done with the local standard, with the IDM, that's a local standard with GDM, or with UDI? What we have to regulate is, IDM is part of the regulations that have been developed by Colombia, that standard. And so the use of the new ID of the local standard with other components, it's something that we're analyzing as part of the process. And the point here is that, and I also want to answer the question that is the next question, that why didn't we adopt a UID that is international? Well, the first point was that Colombia has different type of regulations to what can be seen in the region. But the main issue is that we have to have a control on the information. And that control on the information is provided by a public entity. And the idea is that the information has to be held by the ministry as a whole. In that process, well, what we're analyzing is, with all of these technologies, to try to do other type of standardizations, to do the codifications for the case of the UID. And this is what the Ministry of Health is working on, and that is why the regulations have not been issued. However, and the solution that we might find would always be an IDN, but using any other of the combinations based on the EU IDM or the GDM with the local component, as I just mentioned it. Well, thank you very much. And I think that your presentation was quite interesting, because the last question that we have here is also for you, Oscar, and it says the following: if the Ministry of Health did an evaluation of regulatory impact, has the MOH conduct a regulatory impact assessment on the semantic standard, particularly following GRP requirements under DNP? In particular, has an RIA been conducted analyzing the impact on patient access, given that manufacturers may comply with a Colombia unique semantic standard? The semantic standard is not unique for Colombia. If we go back, the topic is that we are using DNP, and that is the generator of the generic term, and we are not using something that, or developing that process from scratch by ourselves. And that's the point, when the analysis was done and the procedure was done to decide how this was going to be done, that was the first situation. We're going to use the DNP as the main generator of this term with the process to assign the code. However, with the process to assign the code. But what they're referring of the analysis and the regulatory authorities, I think that here we have a point that actually is not part of this presentation, but the topic is, when we talk about regulations, is because we are working on a process where we have the characteristics of the product, and that characteristics of the product are for that specific product. And so we are taking the process, a different type of process, where we have a product, the manufacturer produces their product, complying with all the regulations and the standards that are current, and then that product is set there, and that's where they're going to request for the code. So it's like the other way around. That is why we do not have analysis regarding the regulations and following those steps, but it's a good point, that we did an assessment of what was the best semantic standard to follow, and that was the MDM one. Now, regardless of the fact that at the end we could use the codification that could be used for for UDI, or the one that we have internally here, Thank you very much. I think that that clarifies this point really well. And I'm glad that it was asked because sometimes those confusions are the ones that normally mix us up when how the regulations are being done. But thank you very much for being very clear with your presentation. I think we have no more questions. And there are no more questions. If you have any other question, just take advantage of the time. There are no hands raised, no other questions. So then I would just like to thank all the panel members for sharing your experiences, for talking about the challenges, and also for mentioning the solutions that they found. I think that this is quite valuable information for the regulators that are participating here in this seminar, as well as for everybody related to the industry, because you might have a better understanding of what was the reasoning behind the solutions that we found or the decisions that we make as regulators. I would now like to pass the floor to Vesa Bonici so that she can give the closing remarks for our seminary. So thank you very much, Vesa, and you have the floor.
Thank you very much, Patty. So this brings us to the end of the second webinar on UDI. Last week's webinar covered the fundamentals of the UDI systems and the overview of IMDRF documents. And today we had the pleasure to have representation from industry, healthcare provider, and regulators coming together to share their experience and their expertise on this topic. It was a great opportunity to learn about the challenges, the benefits, and what it takes to implement UDI. In both sessions, we heard the importance of having one global UDI system, a system that ensures medical devices can be identified and tracked across the medical device ecosystems, which involves regulators, industry, hospitals, and even patients. We heard that UDI is a key component in ensuring traceability of products and adequate scope of product recalls, adverse events reporting, and the possibility of using UDI to identify falsified or counterfeit products, really improving quality of medical devices overall. Achieving this vision to capture and share product information globally represents a big task, and we realize that. It also is a great opportunity, especially in a rapid evolving environment where we must act quickly to protect public health. I want to take this opportunity to thank the speakers for sharing their expertise today. I think it was a really great session, hearing from all of you. We appreciate everybody's questions and the discussions today, and we hope that everyone has found this session informative, and we hope to continue these discussions and offer other webinars in this topic in the future. So with that, again, thank you. And I think this concludes our webinar. I want to give an opportunity to Sandra as well, in case she has any other housekeeping remarks. Thank you.
Lisa, thank you very much for your remarks. And I don't know if it is still an opportunity, as we got three additional questions, and taking advantage of the remaining minutes, is it possible for us to go over them before finally closing the session?
Yes, I think we can take those three remaining questions.
Thank you, Patty. Can you help us with those?
Thanks, Patty.
Sure. Okay, so the first question, it's an anonymous question, and it goes to Oscar. So Oscar is very famous today. Se requerirá al fabricante que utilice el estándar semántico único para
Will the manufacturer be required to use the Colombia Unique Semantic Standard in order to have their medical devices registered in Colombia? Nope. We're saying that all health registries will have to go through the process of obtaining the code, but the two procedures are not connected. There is actually an additional process for those who have it or already have it, but they are not connected. The two processes are not connected. We see that the topic is that I have a registry, a health registry, based on what the standards specify to date. And based on that huge framework that is that we did it, and with that, there's no way to introduce the other one. Okay, perfect. And the next one said, okay, are you considering the execution of a pilot before issuing the regulation for the semantic standard to validate its efficiency and possible implementation? Well, actually, a pilot was already done for UDI specifically, and that is why we decided to take like part of that process, and that is why we are doing the necessary assessments to verify with the Ministry of Health to verify how we can use that standard that we're thinking about. But let's say that additionally to that, there's nothing else that we're planning to do. You know, we did that at the end of 2020 and even I think June or July of 2021. So that's when we ran the pilot test to do so. Perfect. Thank you very much. So Sandra, pass the floor back to you. Perfect. Thank you very much. And I want to thank everybody for your participation to date. I think that it has been quite illustrative and very good to see all the information that they shared, to have the point of view of the regulators that are at different phases of the UDI implementation, to learn or reiterate how important it is to have a normalized system that will allow us to have a common language is something that was also present here and clearly stipulated, you know, the perspective of the challenges and of the benefits that we can get, you know, both in the industry and in the healthcare providers areas would show us that we have challenges and opportunities in the future with all the countries that are in the process of implementing or developing these type of regulations, and for those countries that are thinking about the incorporation of the same so that they can really take advantage of all of these experiences. So thank you very much for the participation of all of our speakers. I think that this conversation has been very enriching also, and we hope to see you in the next series of webinars that we're going to launch during the month of March that are related to the first seminar that we held last year regarding the use of international standards and the evaluation of conformity. So wait for our news to this regards, and hopefully you will all participate there. Patty, thank you very much. Yes, Patty, there is a question, I think, about the recording. If the recording of the seminar is going to be available, yes, everything will be available. And so we just wait for our emails with the necessary information. So thank you very much and have a great day.